Welcome, everybody. My name is Carmela Tartaglia, and I'm happy to welcome you to the Canadian Concussion Center's webinar series that's sponsored by the Laborers International Union in North America, LIUNION. I'm pleased to be moderating this webinar series that is developed for individuals that have suffered a concussion, their caregivers, and healthcare providers. The sessions recur every other week, live on Tuesday evenings from 6 to 7 EST, and the sessions are recorded and they're available for subsequent viewing on the CCC website. The sessions focus on various aspects of concussion and include an expert speaker that presents for the first half of the session, and it's followed by a question and answer period for the duration. We would ask that when you have a question, you enter it into the Q&A section of the Zoom, and that you would see the Q&A icon on the bottom right of your screen in the Zoom webinar application. Once pressed, a window will open to submit your question. If you have any technical questions, please enter those in the chat section and Christian will be happy to help you. So before proceeding further, I'd like to acknowledge the Indigenous peoples of all the lands that we are on today. Even as we meet virtually, it's important to recognize the lands we each call home and reaffirm our commitment to improving relationships and understanding with local Indigenous peoples. From coast to coast, we honor the ancestral and unceded territory of all the Inuit, Métis, and First Nation people that call this land home. For this evening sessions, it gives me great pleasure to introduce Dr. John Rutka, who's going to present on dizziness after concussion. Dr. Rutka is a professor of otolaryngology, head and neck surgery at the University of Toronto with a subspecialty interest in otology and neurology. He's the co-director of the UHN Center for Advanced Hearing and Balance Testing and the Hertz Multidisciplinary Neurology Clinic. His chief academic interest has been in areas of topical and systemic ototoxicity, canal-based surgery for dizziness, the conservative management of patients with vestibular schwannomas, time trends in surgery for chronic ear disease, and the evaluation of dizziness in the head-injured patient. His CV lists over 130 peer-reviewed publications and 4 textbooks in addition to numerous books, chapters, supplements, non-peer-reviewed articles. Before he begins, I'm going to, I think Christian puts up a poll to allow us to know who is attending this evening's webinar. Okay, so please let us know which these categories you fall into. All right, thank you. Okay, so now I'm going to hand it over to Dr. Rutka.
Okay. Okay, well, thank you very much, Carmela, for the kind introduction. And I'm just going to open up my presentation here. I presume everyone can hear me, and I presume that everyone can see my slide presentation. And again, thank you for the opportunity of talking to you. We're going to be talking about dizziness after concussion. I am really I have an interest, I should say, in dizziness in the head injured patient. And specifically, I have a relationship with the Workplace Safety Insurance Board. And so I'm going to present some of the data that we've seen in individuals who've had head injuries, again, work related. So again, I'd be pleased to answer any questions that you have after my talk is finished. And again, dizziness is a very common complaint that we see after concussion. So what I'd really like to do today is to show you a little bit about what the literature says about dizziness following a concussion and appreciate the role that vestibular rehabilitation therapy plays in the management of the dizzy patient following a head injury or concussion, and for you to learn about what physical therapy maneuvers are available for treating post-traumatic benign positional paroxysmal vertigo, which is the most common of the inner ear problems that we see after trauma. And then also for those who are perhaps professionals and those who are affiliated with care of patients with concussion. When do you refer someone for management of their concussion, perhaps to a specialist or perhaps for a rehab therapy, and what are the red flags that we look for? So we're primarily going to concentrate on the vestibular part of the inner ear in the presentation. And this is basically a stylized diagram of the cochlea here for hearing and the vestibular apparatus here, which contains semicircular canals and what we call otolithic organs, which are found in the central part of the vestibular area. They are connected, if you like, by the vestibular nerves and will transfer electrical information from these sensory end organs to the brainstem, and then the brain will process the information and will help us with our balance, will help us prevent us, from having visual blurring when we move quickly, will prevent us from falling, so on and so forth. So when I see someone who has complaints of dizziness, the question is basically what is going through their minds, and not only their minds, but my mind as well too. And so what I really want to know, is there evidence for serious pathology involving the brain in individuals who have complaints of dizziness or imbalance? I'd like to know whether the dizziness is related to a recurrent vestibular or inner ear cause. I would like to know, is there a failure to compensate for loss of balance or vestibular function after the injury? And if that's the case, well, why is it? Why don't some people get better? Why do some people get better relatively soon afterwards? And again, we would like to know, are the symptoms being magnified or are they arising from other causes outside of recognized inner ear pathology? So just a few facts. I think many of you know this, but if not, headaches, neurocognitive, neuropsychologic complaints such as memory loss, troubles concentrating, focusing, following directions, hypersensitivity to light and noise, etc., are very common after head injury, after concussion, and dizziness as well joins that triad. And those are really the three most common causes, most common symptoms that we see post-head injury. Um, Another fact is that despite my talking today about, disorders of the inner ear specifically, organic or pathologic inner ear disorders after trauma are relatively rare, and I'd like to show you evidence for that later on in the presentation. And most causes for dizziness sometimes are unknown or secondary to other medically unexplained or non-organic factors, such as could they be amplified by a mood disorder or anxiety, for example. And then of the inner ear disorders, benign positional paroxysmal vertigo is the most common recognized one that we see and one that we can treat actually, and that's the good news about it. So we use the words dizziness and sometimes we use the words vertigo. And again, the question is there a difference between the two? And the answer is yes. Is all vertigo is dizziness, but not all dizziness is vertigo. And by vertigo, what we do mean is oftentimes there is a hallucination of movement. You may feel like you are spinning or circling, your environment is spinning or circling. If you remember when you were perhaps younger and spinning around very quickly and then stopping, you kept on spinning, or you might fall, that sort of thing. And that's typically what we mean by vertigo, it's a hallucination of movement. But sometimes we use the hallucination of movement to actually provide us some pleasure. So if you go to an amusement park, for example, and you're on a roller coaster, you are challenging the inner ear and specifically the otolithic organs, which are responsible for gravity perception. So here's a good example of someone on a roller coaster, or many people on a roller coaster, and they'll experience what it's like to drop very quickly, and you'll be stimulating the inner ears because of that. So we do have specific organs inside the inner ear that look at how we perceive motion relative to ourselves. And if they are abnormal, then we sometimes end up with complaints of vertigo or imbalance. And we have two types of receptors. We have what they call the semicircular canals, and these are angular acceleration receptors. And what they really comprise of are organs that can sense how we move our head in different directions. And that's important because there's a reflex that arises from the inner ear. It's called the vestibular ocular reflex. And that's what allows you to move your head in an equal but opposite if you like, you move, it allows you to move your head, but your eyes move in an equal but opposite direction so that you don't end up with something called visual blurring. And I guess the only analogy I can use, if you remember the old Handycam cameras when you were taking, for example, videos and you're moving the camera up and down. Well, obviously the person was moving up and down as well too, and that gave you sometimes a bit of if you like, visual distortion. But with the vestibular reflex, if it's intact when you move your head quickly one way or the other, your vision is firmly fixed. We also have other organs inside the inner ear, and these are called the otolithic organs. And specifically, there are two types. There are the utricle and the saccule, and both are responsible for perception of gravity and linear acceleration. So, for example, if you're starting or stopping in a car, that's what those organs are used for. And although we don't really notice too much with regards to gravity, if we're astronauts and we go up into space, one thing that they often develop is space sickness. And for the first day or two in space, astronauts are actually quite sick because they no longer have the effects of gravity on the end organs of the actual otolithic organs themselves. Now, sometimes when you have an otolithic abnormality, you can have really quite a serious problem. And there's a condition called a drop attack. And this is where you have a failure of otolithic organs that occur acutely. And this is just a video that's taken from someone's outside camera in their home. And this is someone walking and they're having a drop attack. And I'm glad, although it looks terrible, I'm glad that she didn't really injure herself too badly. But what you saw there is as she was walking, she was actually pushed and pulled backwards, and she was unaware of what was happening. And those are called drop attacks, and sometimes they can actually be quite serious, but they can be seen in conjunction with people with inner ear problems. Well, balance itself is sometimes synonymous with dizziness because people will say, well, I'm dizzy, I have a balance issue. Well, balance is actually much more complicated, believe it or not, than the cessation of vertigo, which we believe usually arises from the inner ear or perhaps from the brain itself. But your balance really depends on information coming in from sensory end organs, vision, for example, being able to feel where your hands and feet are, called proprioception, and from your inner ears. And all this information is taken into the brain, and then there's central processing of this information to allow us, for example, to walk, to jog, to exercise, to perform tasks. And so it's a much more complicated task, basically, than just looking at someone who has vertigo. But again, people that have vertigo can have problems with their balance as well. When patients have problems, for example, with dizziness, we do send them for testing. We can check how their eyes move relative to head movement, which is called the vestibular head impulse test, looking at the vestibular ocular reflex. We can measure gravity receptor function and linear translation function with a test called vestibular evoked myogenic potential test. And one of the very old tests was the water test, where we put water of different temperatures into the ear, and then we would measure a response called nystagmus, which is a rapid rhythmical movement of the eyes, and we would compare the nystagmus generated on one side versus the other side that would tell us if there was a reduction or a loss of balance activity. And then finally, we can check the brain with imaging investigations such as the CT scan or preferably the MRI scan as well. About 5 years ago, we wrote a paper looking at over 4,000 patients who had had head injuries, and these were compensation patients. And we were able to get some interesting information. So I think that this is actually not a bad paper for people who would like to know a little bit about what happens to the inner ear following head trauma. And what this paper did look at was peripheral vestibular disorders uh, outside of positional vertigo following head injury. And we looked at over 4,000 patients and came up with some interesting findings. But when we look at patients who have had head injuries, for example, and concussions by example, what we actually identify is that we have different categories that typically present. One are what we call inner ear disorders, and they're called the peripheral vestibular disorders. Most of the time, it's positional vertigo, but then sometimes we have other disorders, which are called peripheral vestibular disorders, where patients may have spontaneous attacks of vertigo dizziness that occur for minutes to hours without positional change. We have individuals that will have chronic vestibular disorders, and it's quite possible that the disorder may have actually started, if you like, from an inner ear problem, but then over a time frame, oftentimes months, if not years, it becomes incorporated into higher centers in the brain, and you may have symptoms and diagnoses such as medically unexplained dizziness, which is where we can't find an organic cause for the continuous dizziness that people have. Sometimes we see what's called chronic subjective dizziness, where patients feel dizzy, but we can't find objective findings. There's another condition called persistent perceptual postural dizziness, which again may be on the backdrop of having lost some balance activity, but then the brain not being able to cope for that or compensate for that. And then why is that? And again, another condition called maldebarkment, which is where you feel you're on a boat rocking back and forth. And again, perhaps there was some incident that caused it, but then it's continued to occur. Rarely do we see people who have what they call central vestibular disorders, and this is usually representative in individuals who basically have had issues with regards to significant brain or brainstem trauma. We have a number of people that will have basically injuries to the inner ear, but don't necessarily have all the symptoms that represent a recurrent vestibular problem. And like everything else, we have individuals who they present with dizziness, imbalance, and we do not know what's going on with them. But those are the patients that we follow to see whether they evolve into something more recognizable. So it almost breaks down into quarters, if you like: peripheral vestibular, what we call cognitive vestibular disorders, and then we have cochlear vestibular loss and unknown. Um, Basically, following trauma, we see positional vertigo relatively commonly, at least historically. And then we have individuals who present with classic benign positional paroxysmal vertigo, which is where you have crystals floating around inside of one of the balance canals. And then we have other bouts of positional dizziness that may be positional in nature, but perhaps derived from another part of the inner ear. In recurrent vestibulopathy, it's very similar to Meniere's disease, but without the hearing loss. And you have people that have complaints of vertigo that go on for minutes to hours that arise spontaneously. And then in any individual who's lost balance activity, sometimes they don't compensate for that balance loss, even if the balance doesn't change. And then the question is, well, why is that? And again, we have individuals who present with a history very suggestive that there is something going on inside, for example, the ears, but we really can't find out what's going on. So, of the individuals who had peripheral vestibular disorders in our head injured, group of over 4,000 patients, we found that about a quarter of them had a peripheral vestibular disorder, at least by history anyway. And we found that when we looked at positional vertigo, most of the time it was historical. We examined them, but couldn't find really the cause for their symptoms, even though they had told us that when they lie down, rolled over in bed, looked up, bent over, they felt transiently dizzy. Sometimes we did find typical evidence for positional vertigo, and those are individuals that could be helped with what they call particle repositioning procedures or Epley maneuvers. And then we had other people who had what they call atypical positional vertigo. Yes, it was positional, but we didn't find classic eye movements that we normally see with positional vertigo. And it's quite possible that the positional vertigo is arising from other parts of the inner ear. And rarely did we find people, in a sense, who had these recurrent bouts of episodic vertigo that would go on for minutes to hours. So you've heard of crystals inside the inner ear causing your dizziness. I just want to show you what they look like. This is a posterior balance canal, which is the most gravity sensitive canal. We've opened up into it. I'd like to just show you a video, and this was very hard evidence now that you actually had these floating crystals that would be causing patients to be dizzy when they lay down or rolled over. So now we're opening up into one of the balance canals, the posterior canal. You'll see something white in the center there. That is actually, those are crystals that have arisen from a different part of the inner ear and have actually entered into the posterior canal circulation. We're just removing a little bit of bone edge there so you can see the membranous inner ear part quite well. And here we're going to be using a what they call a rose needle to push down to show you those crystals are actually inside of the posterior canal. And when an individual changes their head in different positions, those crystals can shift and they can actually cause an individual to feel actually quite dizzy. Well, we diagnosed positional vertigo with a maneuver called the Hall-Pikes maneuver or Dix-Hall-Pikes maneuver. And we have the individuals sitting up on a bed, and then we position them with their head over the edge of the bed, and we look for, if you like, objective findings and subjective findings that the patient will tell us that they are dizzy. And in terms of uh, the objective findings, we see a phenomenon called nystagmus that crescendos, then decrescendos. It's associated with a torsional movement of the eyes. The patients feel subjectively dizzy. And when we roll them over, we can do something called a particle repositioning procedure. So I'm just going to give you just a brief, if you like, overview of this what they call an Epley maneuver or a particle repositioning procedure. And then we'll show you a video which will actually discuss how it's done. But here we have particles that are inside of the posterior balance canal. This is the superior canal. And this is the most gravity sensitive canal, which is why crystals tend to land in that canal. And here they are. And this is the end organ over here called the cupula. As we rotate the patient to the affected side, the crystals, if you like, drop down, and then they put a drag on the, if you like, the cupula or the balance canal, and that causes, if you like, an electrical activity to be perceived by the brain as if you're moving. We then rotate the patient over to the other side. The crystals drop further into the posterior canal, and when we roll them over so that their nose is facing the floor, we hope the crystals will travel along the posterior canal and will end up in what they call the vestibule, and specifically on the end organ called the utricle, which is where they arise. So this is really a video by Lauren Parnes, who's a colleague of ours from London, Ontario. This video was made about 30 years ago, so it's one of the really, if you like, historic ones, but this shows you quite clearly how Epley maneuvers are done and what particle repositioning procedures are like.
Maneuver begins with the patient seated lengthwise on a stretcher. The patient is then brought back from the seated to the head hanging position on the side of the affected ear, and the eyes are observed for nystagmus. After a short latent period, which can range from 2 to 10 seconds, the nystagmus response crescendos, plateaus, and decrescendos with a limited total duration of approximately 15 to 20 seconds. In this cutaway model, the fluid-filled tubing represents the posterior semicircular canal. Note the directional movement of the particles as the head is tilted. The head is kept stable for 1 to 2 minutes. Then, with the neck fully extended, the patient is rolled onto the opposite side. With the force of gravity returning the particles to the utricle, the eyes are again observed for nystagmus. If successful, the response will be in the same direction as was seen during the first part of the maneuver. As demonstrated here on the model, turning the patient also turns the affected posterior canal 180 degrees, moving the particles along the canal back to where they originated in the utricle. After about 1 minute of observation, the patient is returned to the seated position, and the eyes are once again examined. When the maneuver has been completed successfully, nystagmus should not be observed. Maneuver begins with...
So that's a very good example of how we do, if you like, an Epley maneuver or particle reposition procedure. And I do note that there are different variations to the theme, but that is basically what we do. Now, I did mention that in our patients that we saw with concussions after head injury, many of them had what we would call syndromes of cognitive vestibular dysfunction. And basically, what we're looking at there is that the head injury may have been causative initially, but then for whatever reason, the brain now, or at least the dizziness now, is arising from other centers in the brain itself. So sometimes this is called functional dizziness. Sometimes it's called medically unexplained dizziness. In other words, we don't find a recurrent inner ear cause for the symptoms, and perhaps, if you like, the symptoms are being incorporated from another part of the brain itself. And so generically, some phrases that are often used are things such as medically unexplained dizziness, chronic subjective dizziness, non-organic dizziness, etc. But we have defined diagnostic entities that you'll be reading in reports from time to time, or what other physicians or healthcare professionals may say, things such as chronic phobic dizziness, this condition called persistent perceptual postural dizziness, maldebarkment, vestibular, if you like, visual syndromes going into, for example, a shopping uh, mall, supermarket, whatever can bother people, post-traumatic vision syndrome. And so within the medical community, there's general agreement that these diagnostic entities exist and that they're not related to recurrent inner ear dysfunction. However, where the disagreements occur is really where do they come from? How do we treat them? And why do symptoms persist and don't get better with time? So with medically unexplained dizziness, or perhaps with functional neurologic disorders, they all seem to have similar features, and there's often considerable overlap in how an individual will present. And the epiphenomenon, in other words, what starts the ball rolling, may be an acute traumatic vestibular event, for example, on the backdrop of a concussion. But the generator now for if you like, the chronic dizziness that people have may be coming from higher cognitive centers within the brain and not necessarily from recurrent inner ear issues. Now, in individuals who have, if you like, functional neurological dizziness or medically unexplained dizziness, there seems to be a significant, if you like, overlap and interplay that is not known on, again, recognizing your pathology. Vestibular rehab therapy, which is really the workhorse in trying to help people who have complaints of dizziness, is unlikely to provide significant benefit in many individuals. Oftentimes, because we believe that the symptoms are arising from higher cortical centers in the brain, we will treat people with sedatives, for example, antidepressant therapy to see if that helps. And it's not that you may be depressed, but there may be biochemical changes that have happened within the brain, and there seem to be extended use for many of these medications under the treatment of a recognized professional. There can be a role for cognitive behavioral therapy at the level of the family physician or another treating, if you like, healthcare professional to teach just better ways of coping. And again, in any individual who, following concussion, let's say if you had an individual with a motor vehicle accident, for example, if there are issues for the guards at work, the interplay of litigation, compensation claims, workplace issues can adversely affect any treatment for an individual who has chronic, if you like, medically unexplained dizziness. One study that we did about, I guess, about 5 years ago now, which was heavily cited in the world literature, is that we have a psychiatric arm to our dizziness clinic at the University Health Network. And what we had identified is that when we looked at individuals who had chronic dizziness, where we thought they may have had another generator for their symptoms outside of inner ear recurrent dysfunction, we found that in those individuals who were pursuing a legal claim, we actually found that this actually may have prevented them from getting better with regards to their chronic dizziness. And when their legal claim was settled, or insurance claim was settled, or workplace issues were settled, they actually were able to respond much better to the treatments that were provided, through, if you like, our psychiatric or neuropsychologic arm of our clinic. So please remember that in any individual who has a loss of balance activity, the brain can adapt. There's a concept of neuroplasticity. In other words, the brain can pick up and, if you like, deal with loss of balance activity from one inner ear, for example, for the other, and does so using other, if you like, sensory input from vision, proprioception, and from recurrent exercise where you stress the situation. And this really performs, in a sense, and really is the hallmark of how vestibular rehabilitation therapy works. You're trying to promote compensation for any balance loss that occurs. You're trying to, if you like, promote, increased functionality, exertional tolerance, and make an individual, again, feel somewhat better by having the brain adapt. And this is how it's done through neuroplasticity. So, in my opinion, I think that vestibular rehabilitation therapy is very important in individuals who have sustained a vestibular loss but have problems compensating for that loss. And we'd like you again to understand that there are different aspects of vestibular rehab therapy, usually done best, in my opinion, with an advanced practice physiotherapist who's studied in this area. And we look at balance, and we look at movement, and we look at, if you like, stressing the system so individuals can compensate better if there's a visually rich environment, for example. And these are what, if you like, advanced practice physiotherapists do. They try and promote compensation by bringing in other sensory input. They try and improve an individual's quality of life by making them feel as if someone is with them, looking after them, and again, will be with them to help them with the exercises themselves. It is a bit of work for the individual who's going through these treatment sessions. Yes, it doesn't always work, but it does work in individuals who have a fixed balance loss. It also seems to work in individuals who are well motivated as well. And we also know that individuals who, again, wish to become active, more so, and if we can, if you like, remove any of the barriers to their recovery, will do well with vestibular rehab therapy. But again, one has to be patient with this. So, what are the red flags for dizziness? Who should I refer? When should I refer? Well, those people that require a medical assessment, either from, if you like, someone like myself who's a neurologist, or someone, for example, who may be a neurologist or involved in the looking after patients with head injury post-concussion. Again, we would like to see those people who have persistent symptoms of dizziness and imbalance that does not improve or resolve over a 3 to 6 month time frame. That's the usual trajectory that we look at. Most people do seem to get better within that time frame, but if they don't, then we would like to know why that is. We would like to see those individuals who have complaints of episodic vertigo or dizziness that's not positional in nature, that lasts for minutes to hours, or those who have unprovoked drop attacks, as you saw in the video that I presented. So, spontaneous attacks of vertigo in minutes to hours or unprovoked drop attacks, those are people that we would like to see because we believe there could be, if you like, a peripheral vestibular cause for their symptoms. And also those patients who may have complaints of hearing loss, tinnitus, perhaps a change in your sense of smell or taste. We'll go over that a bit later if you like. And who do we refer for vestibular rehab therapy? Well, those patients who have a history that's highly suggestive for positional vertigo. They get dizzy when they lie down, roll over in bed, look up, bend over. Perhaps they're mechanics to go under a car, for example, look up under the undercarriage. These are people that we would like our physiotherapists to see. Any dizziness that seems aggravated by head movement. Perhaps you have an uncompensated peripheral vestibular loss, and physiotherapy may help with that. And those patients who may have dizziness where there's motion relative to themselves. We call it a vestibular visual mismatch syndrome, supermarket syndrome. Sometimes it can lead to motion sickness itself. And so just finally, there are some interesting factoids that we've learned over the years looking after patients, who've had head injuries, sort of a thing. And again, just one caveat is that what we find with vestibular rehab therapy is unlikely to provide benefit in an individual who may have an underlying mood disorder. And we also see this with regards sometimes to treating them for other reasons. So again, just keep that in mind. If there is any barrier that could be an underlying mood problem, that should be looked at and treated. And then finally, these are some interesting facts, if you like, or questions. If you were to ask me, I presented this before, but if you ask me, of all the people I've seen over my years looking after patients with head injuries, what's the most dangerous job in Ontario? There are lots of dangerous ones, but in my opinion, the most dangerous one is actually those who do tire mechanics. Tire mechanics, where they have looking after tires on the large trucks. Sometimes when they explode, you get some very, very terrible injuries, and which is why most times patients, or most times workers who do this sort of work, are put into a cage, if you like, and they're put into, if you like, a hazard suit that will help protect them from explosions, which is the cranial nerve that is injured the most in head injury. It's not the nerves of hearing and balance, but it's actually the olfactory nerve, the nerve of smell. And that's because if you have a head injury, oftentimes there's a shearing effect and it can involve the olfactory nerve. And then one of the questions I always wondered is whether if you did lose your sense of smell, whether that indicated a worse prognosis for return to work. And that basically comes along with understanding that if you do have a shearing effect of the olfactory nerve, it's usually involving an anterior posterior direction, for example. And if there is a shearing effect, right by where the olfactory nerves are, you have the frontal cortex, and sometimes that can be injured. And therefore, if you have cognitive problems, neuropsychological problems following head injury, olfactory dysfunction may again indicate a worse prognosis possibly. So that's the end of my presentation today. I would be willing to answer any questions that you may have, and I look forward to further discussion as the session goes on.
Thank you very much. That was very enlightening. Um, I'm always fascinated by the inner ear. It's such a intricate area. So we're going to open it up to questions and answers. There's already quite a few of them. So one question is from somebody, I experienced mal de débarquement, being seasick for months after a cruise. Years later, I now have prolonged concussion symptoms. I'm assuming after a concussion. The dizziness improved, but still have daily headaches and screen sensitivity. Is there a connection between mal de débarquement and, um, I guess, having that pre-concussion?
Yeah, I presume that there probably is. Again, the question is, where do the symptoms of maldebarkment come from? We certainly know the triggers, which seem to be individuals who've taken, for example, a boat trip, a cruise, sometimes on airplane trips, so on and so forth. One of the interesting findings in maldebarkment is that when we investigate people, we do all the inner ear testing, invariably it's always normal. We never find an abnormality, but yet people can be quite devastated by maldebarkment, and we'll all experience it if we're on a boat long enough, and then when we try and get on land, it takes time to get our land legs back, sort of a thing. So then the question is, where does it come from? Where is it originating? One thing we can say, probably for the most part, is it's not arising necessarily from an inner generated signal, but yet somehow how the brain and the cortical center is perceiving, if you like, motion relative to itself, and then becomes incorporated such that you always feel that you're moving, but you're not. It does obviously give rise to conflict and may give rise to other symptoms as well.
Right. Okay, thanks. Another question, is tinnitus after concussion related to the inner ear? Is there a way to resolve it?
Uh, it could be related to the inner ear, it could be related to higher auditory centers as well too. And one of the problems is that we again, you ask enough questions, we don't have answers to everything. Tinnitus means unwanted head noise. It's very common after concussion, no question about that. And does it represent inner ear injury? Possibly. Oftentimes, when we do inner ear testing on patients, specifically the hearing test, we find it's normal, but yet people have that condition. And if tinnitus persists, for example, then we do wonder whether, again, the signal is incorporated somewhere in the higher centers of the brain, which is one of the reasons sometimes medication treatment is suggested. Medications such as nortriptyline, if you like, amitriptyline, even the SSRI and SNRI classes of antidepressant therapy have been indicated as well. And there have been people writing about, for example, neurochemical imbalance in the brain giving rise to this symptom.
Right. Okay. Yeah, and it's very troublesome to patients, especially when they've never had it before.
Yeah.
Um, Another question, can vertigo be triggered from barometric pressure changes? And can that be related to post-concussion vertigo?
I would say that we have had patients who will tell us that they do feel dizzy when there is barometric change. What I can't do is give you a actual physical reason why that is, but we do know that other, environmental factors can bother people. For example, who have migraine headaches or sensitive. So when the weather changes, they notice it. For example, people who have arthritis notice when the weather's changing as well. So there's something there, but exactly how it happens, I really can't tell you that.
Right. Somebody asks, if I had a history of vertigo before the concussion, does that mean anything for dizziness post-concussion?
Yeah, I guess it's certainly in the context of positional vertigo, for example, in that little entity there, if you've had positional vertigo before you've had a concussion, then yes, you may get a bit more of it after your concussion, because
Mm.
again, you may be releasing more crystals that would get into the posterior balance canal circulation, giving rise to symptoms. Yes, and I guess that, we can have changes that occur, for example, in the inner ear, to actually cause even recurrent attacks of vertigo, following concussion. And one of the things we didn't talk about today is that we have a investigation that I guess is being put to more clinical use now, and it's called a delayed contrast MRI scan of the temporal bones. And what we do is give individuals uh, an injection of a compound called gadolinium, which is a contrast agent, we wait for 4 hours, and then we see the gadolinium is absorbed into the inner ear, and it forms a contrast with the delicate lining membranes inside the inner ear. And this can tell us if there's, again, injury to the inner ear because we see expansion of those delicate lining membranes. And if you like, the classic condition where that happens is Meniere's disease, but we do see it after trauma. We see it after viral infection and everything else. And one of the complaints that patients often have if they have an inner ear problem that's so difficult to treat is that of basically a pressure sensation in their ears.
Mhm.
Oftentimes, you go and see your family doctor or your general ear, nose, and throat practitioner, and they'll say, "Oh, it's a eustachian tube problem." But we've been kind of surprised that when we start doing, MRI scans on patients who have not benefited from the usual treatments that we give them, that sometimes we actually do find these changes in the inner ear where you see the delicate expansion of lining membranes there. So something's happening there.
Mhm. Yeah, and I guess for effective treatment for tinnitus, I guess the ones you mentioned were that some of these, like nortriptyline, Elavil, and SSRIs, like sertraline,
Yeah,
escitalopram,
right.
SNRIs, were the treatments. So somebody asked that.
Yeah.
Um, so somebody is asking, what about dizziness or vertigo that's caused or worsened by visual stimulation, like if they're walking in a crowded mall with a lot of moving people? Do you
Yes.
hear that?
Yeah, matter of fact, that we see that quite well, we see that quite commonly actually in individuals, for example, who've had a vestibular loss of some type. So we see that, and so that's why we often investigate people to see what, their inner ear function is like. And if you have a stable peripheral, in other words, inner ear loss of activity, and it's not fluctuating or changing, uh, again, vestibular rehab therapy can be quite helpful in that. Because we try and do desensitization exercises, we try and deal with that situation as well too. Sometimes we're successful, other times we're not. We may have to use medication to see if that sort of suppresses if you like, the neurological system a little bit, because it's quite possible that you're not filtering out information that you once did, and you get bombarded by all this information. It's really hard for the brain to keep track of that if that's the case.
Yeah. Is there a timeline for when you need to do the vestibular rehab within, like, I mean, I guess post concussion?
Uh, Again, like everything else, it's more of a motherhood statement, but the earlier the better, obviously. But vestibular rehab therapy for people who have, if you like, a condition such as benign positional paroxysmal vertigo, can be done at any time, really. And
Mm,
again, we can also help people who've had a fixed vestibular loss at any time as well, too. So those are the classic examples of something where vestibular rehab therapy can certainly help. And again, we always try and encourage people to be active after their head injury, although we do know sometimes that, or that's concussion, and sometimes you take 2 steps forward and it's 3 steps back. So, you have to be careful and don't push it too much. But, again, gentle, if you like, exercise, moving, trying to get back to what your activities were before you had a concussion are very, very important.
right. Somebody's asking, is nausea related to dizziness?
Yes, it is. It can be. We have specific tracts that arise from the inner ear. We have the vestibular ocular reflex, which I mentioned earlier. We have what they call the vestibular spinal reflexes, and those prevent you from falling.
Mm,
So if you have an otolytic problem, you might fall. We have what they call vestibular cerebellar tracts as well, too, and those are tracts that actually go to the cerebellum, which is the area for coordination. So sometimes people who have an acute vestibular loss look as if they're impaired, look as if they've been drinking too much. They're ataxic, they stagger, they slur their speech and everything else. And so, that's something to keep in mind. But the last tract you have goes from the inner ear to the emetic centers in the brain. So
mm,
in the acute vestibular situation, you can become, again, very nauseous to the point of vomiting, which is why any individual who's acutely vertiginous stays still, doesn't move. They try not to move because it makes them feel worse and so on and so forth. But then again, you can continue to have bouts of nausea as well, too. So sometimes it's important to recognize what's going on. Again, vestibular rehab is important to see if we can promote compensation. But we also have other medication that patients can take as well too for their nausea, for example, outside of things such as Gravol, but there are other, again, prescribed medications that may be helpful as well.
right. There's a few people who are asking whether using vision therapy to treat these vestibular sounding symptoms is, I guess, an avenue of treatment.
Well, it's certainly something that patients will do within the context of conventional medicine. Sometimes we can't help people get better, and so they'll look for other options, such as, a vision therapy. Um, it's hard to know how effective that is, in my opinion, and perhaps I'm biased. But it is something, again, I just have to tell you that for those who wish to proceed towards that, it's not covered by the healthcare system. So, again, just remember that there'll be a private cost involved in that. And also, again, from my perspective, I would rather favor, things such as vestibular rehab therapy, medication treatment if that's required, and again, a good, compassionate, physician, healthcare professional looking after that individual, because you're going to have problems after concussion, and you need someone there for you.
Yeah, no, it's true. We always say, it's very complicated because there's so many things that get affected. And so
Yeah,
sometimes we try to treat one thing and makes other things worse, but also when you treat one thing, other things can get better.
yeah.
Um, Somebody's asking, after 2 years, I still have supermarket syndrome when I see live music or a live play. I don't actually know what that is, but do you? Have you ever?
Well, I mean, yeah, well, that's usually just a visual vestibular, mismatch or intolerance. But supermarket syndrome is where you basically obviously go into the supermarket, you're going down the aisles, and there's so much visual input that's coming to you that you absolutely, really just can't, your brain just can't, if you like, uh, focus on what's important. So I think there can be a situation that happens. The classic example I use for other individuals is those of airplane pilots. Like, if you think of an airplane pilot landing a plane, I mean, they hit the tarmac and they land the plane, all's okay. But if you all of a sudden bombarded by sensory information coming in from the periphery and everything else, you may actually lose where you are. So again, you lose that filter, to be able to get rid of the extraneous information that's not important. And I think that in concussion that happens as well too. You may not be able to get rid of all the signals coming in, at least the ones that are the most important for you. But with all this information coming in, it really does put a number on the brain, as they say, to try and figure out what's going on.
Right. Somebody's asking, when is CERC indicated and for how long should it be taken?
Beta histine or CERC is a medication generally recommended for the management of people with episodic vertigo. Uh, Again, in the context of a condition called Meniere's disease, which is where you have fluctuation of hearing, noise in the ear, a pressure sensation, and recurrent attacks of episodic vertigo. Usually in our practice, we would give someone a trial of the medication, usually one tablet twice a day, 24 milligrams twice a day for about 3 months. And if that didn't provide any benefit, then you could jettison it. But if you found that it did work or provided benefit, then you could continue to use it. And we usually say use it for about 6 months, and then you can start to wean yourself off if you again receive benefit from that.
Okay. Is vestibular rehab therapy OHIP covered?
The answer is no, as well, for the most part. It's quite possible you may be able to get some physiotherapists who work in hospitals who might be able to help you in that regard, but no, for the most part, it is a private pay as well.
Right. Okay. Does practicing balance help everyone to return to pre-concussion or just some people? What works best?
What works best is being active and trying to get back to your activities for daily living before you had your concussion, if you could do that. I think there's no downside to doing this rehab therapy. There's no downside to it. Much of it is self-directed, but the point is I think that you will have some improvement. Do you ever come back to normal? It's possible you may not, because you have a neurologic deficit and your loss of activity, but you can certainly make yourself feel much better, no question, by trying to promote compensation.
Right. Um, is it important to have this diagnosed with the test, or can you jump into vestibular physiotherapy, I guess, without all the elaborate testing that is done in the, yeah.
No, you can jump directly into vestibular rehab therapy. Again, it works best for those patients who have an uncompensated balance loss, and for those individuals who have positional type dizziness. That's where it works best. So those who have dizziness with movement of
Okay.
their head, for example.
Yeah. Somebody's asking, they have had 10 sessions of vestibular therapy and have very limited improvements. Anything you can recommend? Or is there a number of sessions that somebody's expected to see improvement or
Yeah, I think that that would be, again, a good reason to be further investigated if you haven't been investigated, so that you'd like to know, well, why is it that you haven't improved? So, you'd like to look, for example, you know, do you have any problems with your vision? Do you have any proprioceptive problems? For example, are you diabetic and you can't feel your feet, that sort of thing? Uh, you need to have more investigations, and we do the inner ear investigations to see. Sometimes people don't compensate if they have a bilateral vestibular loss. For the most part, vestibular rehab therapy works well in individuals who have a unilateral loss, but when you get a bilateral loss thrown in there, that's very difficult to compensate for. So, that's the reason why we do the test to make a diagnosis. And then for the diagnosis, we can sometimes make a better prognosis, if you like, and obviously arrange for better treatment.
right? And I guess somebody's asking how, like, or the question is about really how many years after can you still hope to get improvement from vestibular physiotherapy? So if the concussion was like 2 years ago versus 5 years ago, do you think there's a timeline? Or yeah,
Yeah, I mean, obviously, the earlier you treat something, the better. I would think, But first of all, what's really important is a diagnosis. Like, why are you having your problems? Can we hone in on that? Can we provide, a diagnosis for the condition as to what's happening? And that's where the special testing comes in. That's where you have, sometimes imaging investigations are done as well too, to look at the brain itself. Maybe you have gotten older, there's neuronal dropout. It's hard, kind of, you lose that ability to compensate, because you've lost a number of, if you like, neurons as time's gone on, so on and so forth. So I think there's always hope that you can get better, but the question is what the cause is, and that's where we have to look at if you haven't had those investigations done.
right. Somebody's asking, does the Epley work on just one, I guess, problem? Yeah,
It works best on those individuals who have positional vertigo, which is due to crystalline disease, if you like, crystals in the inner ear. And the answer is yes, that's where it works. But again, with the Epley maneuver, if you do it frequently, again, you do uh, again cause some degree of compensation or habituation. So, that may help a bit as well. But again, it depends on, where the problem's arising from in the inner ear, for example, if you have positional vertigo.
right. And now there's a question on, if you have the dizziness vertigo persisting, but it happens actually quite infrequently, but it can occur years after the concussion. Do you think that's still related to that, or, could it be
Oh,
that
yeah, yeah, yes, 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 we see that not infrequently, yeah. And, we have to assume that is, and now that we have, other investigations, we can definitely see that. Um, so, for example, if you have any element of injury to the inner ear, maybe you're dizzy at the time of your concussion and it got better and went away. What I don't know is what's happened to the inner ear over the years. And so you can cause changes in the inner ear. And then what we do is we see years later, you might start getting other bouts of dizziness that occur maybe spontaneously or maybe positional in nature. And we see a spectrum of inner ear disorders in individuals in a delayed fashion. So those are things that we look at. And again, now we have some more investigative tools that we can use. But no, that's not unusual, especially if you had some dizziness initially after your concussive event.
right? Okay. Somebody's asking, can the Epley maneuver make the vertigo worse?
The answer is yes. Thankfully, that's in the very, very, very few people in the minority, matter of fact. But it can make the dizziness worse. Usually, it's transient because sometimes if you have a crystalline load, if you're able to take the crystals and put them back to where they came from, all of a sudden, maybe a big load or what seems to be a big load of crystals lands on, the utricle, which is part of the oolithic organs, and you can feel very imbalanced for many, many days after that. And then gradually you do get better. Most of the times, one would not anticipate that the maneuver would actually make you worse.
Right. Okay. And I guess for the last question, and this is something we were talking about before you started, was how do you define dizziness? When people say that, what does it mean? How can we tell people to, help us figure out what they mean by dizziness?
Yeah, well, that's obviously that's a PhD thesis here, but I'm not going to get into it. But you ask people, what we're told is to ask them to describe in their own words what they mean by dizziness. Some people find it's lightheadedness, some people call it giddiness, some people feel that there's a sense of imbalance as if they wish to fall. But again, with vertigo, it's a hallucination of movement. Either you're moving or the environment's moving. And vertigo is usually crisply described. It usually lasts for seconds, minutes, or hours. It doesn't go on for days and days and days and days, just as a general rule. And we also ask questions. So is it coming from the brain or is it coming from the inner ears? And if it's coming from the inner ears, we ask, do you have noise in the head, tinnitus, pressure in the ear? Does your hearing fluctuate? So on and so forth. If it's coming from the brain, then we ask questions, do you have troubles with double vision, weakness or numbness one side of the body, trouble speaking, trouble swallowing, incontinence of bowel or bladder activity, do you lose consciousness, so on and so forth. And that kind of basically describes that. And then finally, oftentimes we have a patient that will be in front of us and we hear a story that goes on and on and on and on. And so if it sounds like you're on the Odyssey or some form of Homeric legend, chances are it's probably not related to something going on inside the inner ear, just as a general rule.
Right. Okay. Thank you. So as we near the end of this evening's sessions, I want to thank Dr. Rutka for his presentation and insights. And a few people have said thank you very much and great presentation. As well, I want to thank the participants for sending all their questions. And as a reminder, all the sessions will be recorded and housed on the Canadian Concussion Centre website and available for viewing at any time you wish to recommend to anyone you know. We will also be forwarding a short survey to you by email to obtain feedback on the session. Your thoughts and input would be appreciated for you to have if you have a few minutes to spare. Our next session is on May 5th, where Dr. Leslie Rattan, who is known to many of you as she is the usual moderator, will be presenting strategies for improving mental health. I also like to let everybody know that we have our upcoming Canadian Concussion Centre Public Forum on June 3rd, and there should be registration available for you. So thank you all for coming, and thank you, Dr. Rutka, and of course, thank you to Christian Peterson, who is the man behind the scenes here and allows all of this to happen. So thank you, and have a nice evening.